Sleep and Common Sleep Disorders by Ken Martin at Kaiser University for Dr. Smith, Psychology 532, Health Psychology class. Sleep and Common Sleep Disorders. Sleep. About 1/3 of human life is spent in the state of sleep. Research has shown sleep is essential to ensure not only well-being, but survival. While the exact reasons for sleep are yet unknown, scientific studies have made progress in answering three fundamental questions. What is sleep? What are its mechanisms? And what are its functions? Research has also furthered understanding of the negative impacts, or sleep disorders, that result from the lack of sleep. This presentation will provide a review of select current literature as an overview of the subject of sleep, with particular emphasis on two common sleep disorders. It will begin with a definition of sleep and include descriptions of the unique qualities that characterize its state. Sleep disorders will then be reviewed relative to their general classifications, with a closer review of the central disorders of hypersomnolence, also known as hypersomnia, and insomnia. The presentation will conclude with a review of recommendations for beneficial sleep hygiene. So let's begin. Just what is sleep? Sleep typically occurs when one is lying down with eyes closed and in a state of inactivity or otherwise at quiet rest. More scientifically defined, Stenberg 2007 stated, sleep is a reversible physiological state with reduced spontaneous movement and responsiveness to sensory stimuli. From a behavioral view, Karskadon and Dement 2011 stated, sleep is a reversible behavioral state of perceptual disengagement from and unresponsiveness to the environment. While one may be externally observed as generally passive when sleeping, internally, sleep is controlled by a complex synergy of psychological, neurochemical, electrophysiological, endocrinal, immunological, and genetic factors. Sleep's elaborate processes can be described more broadly when viewing their unique characteristics, or the stages of sleep. Normal human sleep is comprised of two primary states, rapid eye movement, or REM sleep, and non-rapid eye movement, or non-REM sleep. The characteristics of each state are well defined and measurable as stages across time. The two alternate in a cyclical pattern throughout sleep duration. Non-REM sleep is characterized by wave patterns of brain activity that can be recorded using an electroencephalogram, or EEG. This is an image of EEG tracings for each stage of normal non-REM sleep. Noticeable are the increasing amplitudes and decreasing frequencies as the stages progress from 1 through 4. This is an indication of the individual's shift from wakefulness to deeper levels of relaxation and sleep. A simple definition of non-REM sleep is an inactive yet regulating brain in a movable body. Of interest in stage 2 is the arrow pointing to an abnormally high amplitude wave, which represents a K-complex, and the underlined areas that look like wave compression, which are sleep spindles. These anomalies in the wave pattern are proposed to suppress potential wakeful stimuli, as well as enhance memory consolidation and motor skill acquisition. REM sleep is also characterized by EEG activation with the addition of episodic bursts of rapid eye movement and muscle atonia, which is a state of extremely relaxed muscle tone as evidenced in paralysis. Rapid eye movements are measurable using an electrooculogram, or EOG, and muscle movement is measurable using an electromyelogram, or EMG. This is an image of EEG, EOG, and EMG tracings for normal REM sleep. Evident on the top line is the high-frequency, low-amplitude wave pattern for an active brain. The second and third lines indicate bursts of rapid eye movement, and the fourth line shows muscle twitching. Most notably about REM sleep stage is that mental activity is associated with dreaming, which is accompanied by muscle paralysis, presumably so that those dreams are not fully acted out through movement, although muscle twitching is common. Ideally, the stages of non-REM and REM sleep will cycle throughout the night. Normally, one enters sleep through non-REM stages, with a REM stage beginning after approximately 90 minutes. This cycle will repeat 4 to 5 times, defining a sleep duration of about 8 hours. This histogram is an example of the progression of sleep stages. The pattern shows the transition through non-REM stages to the REM stage across time. Of interest are the regularity in the pattern and the EMG plots of body movement and their correlation with the REM stage. This pattern was recorded from a 19-year-old male subject. Generally, there are no differences in this normal pattern of sleep throughout the night between genders. There are, however, notable differences in sleep patterns throughout one's lifespan. For instance, the first year of life, the REM stage is more prevalent, in that the non-REM-REM cycle is approximately 50 to 60 minutes. This variation from the normal 90-minute adult cycle is referred to as active sleep in newborns. This graph represents the quantitative changes of sleep stages plotted as time in minutes against age in years. SWS represents slow wave sleep, or the deep sleep stages 3 and 4. WASO represents wake time after sleep onset, and sleep latency is the time it takes one to fall asleep. Of interest is the difference in time young children through mid-adolescence spend in slow wave sleep as compared to adults, especially older adults, and the amount of wake time after sleep onset for each group. It is clear sleep is deeper and more consistent for the young. Whether these variations have direct relevance to physical or psychological health is not yet known. However, there may be correlations to the exacerbation of sleep disorders and potential determinants for diagnosis and treatment. Another key component to a normal sleep cycle is the circadian rhythm. Humans are considered diurnal mammals, meaning they are active during daylight and rest at night. The timing of normal sleep follows this pattern and is regulated by what can be described as a centralized clock located in the brain's hypothalamus. The circadian rhythm is triggered by environmental influences, specifically the exposure to sunlight during the day and its absence at night are vital for activating sleep. Disruption of this normal wake-sleep cycle can cause major detrimental physiological and psychological effects. If repeated over time, these disruptions become the basis of sleep disorders. A sleep disorder is an occurrence that influences the structure and distribution of sleep. While there are several sources to such influences, limited sleep duration seems the most prevalent and least understood. Evidence points to the cumulative effect of minor sleep loss and correlated negative behavioral and cognitive consequences. Research has also shown a decline in sleep duration has occurred in the past 25 years. The National Sleep Foundation estimates the economic costs of poor sleep to be in the billions annually due to compromising effects on personal health and public safety. Awareness of sleep disorders and their potential consequences may provide possible solutions. There are close to 100 identified sleep and wake disorders. The key reference for their diagnosis is the International Classification of Sleep Disorders, 3rd edition, recently updated in 2014. Disorders are grouped into the following categories: insomnia, sleep-related breathing disorders, central disorders of hypersomnolence, circadian rhythm sleep-wake disorders, parasomnias, sleep-related movement disorders, and other sleep disorders. The central disorders of hypersomnolence. According to Sadia 2014, these disorders are characterized by excessive daytime sleepiness that cannot be attributed to other sleep disorders, and it is quite apparent they can have seriously adverse consequences. It is estimated that more than 100,000 automobile crashes are caused by drowsy drivers annually. Major disasters such as 3 Mile Island, Exxon Valdez, and the Challenger Space Shuttle were all attributed to sleep-related impairment. According to Maywald and Schenk, the most common source of hypersomnia is volitional sleep deprivation for social or economic reasons. However, when sleep loss is not a choice, obstructive sleep apnea is a common underlying cause. Sleep apnea affects approximately 2% of adult women and 4% of adult men. It is evidenced by loud snoring due to a collapse of the upper airway during sleep. In order to regain airflow, the individual is subject to brief sleep arousals, up to 100 an hour, causing sleep fragmentation. While the arousals are not typically perceived by the individual, they do cause excessive daytime sleepiness. Sleep apnea has been linked to high blood pressure, heart disease, and type 2 diabetes. Contrary to initial findings, however, sleep apnea is not confined to men who are overweight or middle-aged, as it is also evident in children, women, and those of slight stature. However, obesity is considered a developmental risk factor. One of the more prevalent sleep disorders, particularly affecting older adults, is insomnia. According to Sacamano 2014, insomnia is characterized by difficulty falling asleep, staying asleep, or sleep that is non-restorative. Deep sleep gained during stage 4 non-REM sleep is a primary effect. Insomnia can be of short duration or chronic, and both are usually predicated by a stressful experience. Stress factors can include family and/or work issues and childbirth. These can be exacerbated by sleep habits and beliefs. A notable concept regarding negative beliefs about sleep, or negative sleep cognition, has been posed by Yang and colleagues, 2006, as a potential foundation for behavior and emotional arousal that directly affect neurophysiological systems, the consequence of which may be disruption of normal sleep. The flow of effect is depicted in Figure 5, where sleep beliefs, represented as sleep cognition, affects behavior and emotion. In turn, these are posed to directly affect the homeostatic, circadian, and arousal systems, all of which affect sleep. Other causes of insomnia include medical issues, psychiatric illnesses, medications, the use of alcohol and caffeine, and poor sleep habits. Up to 15% of the general population may be affected, resulting in insomniacs having higher accident and absenteeism rates. Studies have also shown insomnia to be associated with higher risk for several other health conditions, including cardiovascular disease and depression. In fact, it has been theorized that depression and insomnia are bidirectional, in that depression may lead to insomnia and insomnia may lead to depression. Evidence also points to chronic insomniacs being in a constant state of hyperarousal due to increased levels of ACTH and cortisol secretion. It is clear that poor sleep may have many negative repercussions on individual health, which in turn may lead to debilitating performance, lower productivity, substance abuse, increased stress, healthcare system strain, increased economic costs, social unrest, environmental disaster, morbidity, and even death. Good sleep hygiene is the suggested starting place to mediate these issues. Both the Centers for Disease Control and the National Sleep Foundation offer education and guidelines in the promotion of regular healthy sleep. Recommendations by the National Sleep Foundation for good sleep hygiene are to establish consistent sleep and wake schedules, even on weekends, create a regular relaxing bedtime routine, such as soaking in a hot bath or listening to soothing music, which should begin an hour or more before the time you expect to fall asleep, create a sleep-conducive environment that is dark, quiet, comfortable, and cool, sleep on a comfortable mattress and pillows, use your bedroom only for sleep and sex, keep sleep stealers out of the bedroom, avoid watching television, using a computer, or reading in bed. Finish eating at least 2 hours before your regular bedtime, exercise regularly during the day or at least a few hours before bedtime, and avoid caffeine and alcohol close to bedtime, and give up smoking. In conclusion, while all the purposes of sleep have yet to be fully understood, it is evident that quality sleep plays an integral part in a healthy physical and mental life. The processes of sleep have been well defined. They are fragile and persistent. Therefore, it is seemingly incumbent on the individual to honor the biological mechanisms in place by following beneficial sleep hygiene and hopefully sleep well. Thank you for viewing this presentation. Following is a list of references.